through the next presentations to realize that shielding is just sort of the vehicle here. Really, the journey is how do you affect a cultural change and do this so that all parties are equally represented and we continue to take good care of patients. So a little bit about background, the implementation and approach in the United States, and then what we need to do towards more global success. And you can see in this example here how this scrotum was not adequately shielded. First of all, just in terms of perspective, we still do a lot of radiography, at least in pediatrics in the United States. Fully 2/3 of our imaging still involves X-ray examinations, while MR and CT and ultrasound tend to be something we think is high-tech and of more value. This is the bread and butter of what we do. The historical perspective includes just a sort of wide-spread change in practice in the 1950s, and fundamentally what we have done up until the last few years has been 60 or 70 years of consistent practice. In 1976, the US FDA did come down with a recommendation that gonadal shielding be performed, and that has been, for the last nearly 50 years, what states have based their shielding practice upon. And this is the Federal Registry from 1976 here discussing the recommendations for shielding, which were predominantly of the gonads and predominantly to help with prevention of heritable risks to future generations, which we know in humans has not been significantly demonstrated, even at high radiation doses. So a number of organizations, including AAPM, NCRP, ASRT, ART, came out with some early recommendations with respect to shielding here. Some of this was based on literature, which you've already seen in terms of why we should be changing the practice here, and I just illustrated these. Now, in 2019, the FDA recommended changing that, they recommended changing their previous recommendation, and it's fully 4 years later till that was realized. It was just in January of this year that that was officially published. The CRCPD, which provides recommendations and guidelines for state practice of radiology, has since modified their guidelines as well. But as you'll see in just a minute, many of the states still have adhered to the previous guidelines. And this is a survey that was done and reported in the newsletter through CRCPD in February of this year, and it just went through what the current status is with a number of states. And I won't go through each individually, but you can see some states are changing, some states are considering changing, some states aren't doing anything at this point in time. So it is a continuous practice change now. So as I said, in January of 2023, that final recommendation by the FDA was accepted, and I think this is fundamentally what the rest of the United States was waiting for, was this official policy so that the change can be implemented. And again, it's going to take a while. So now that this recommendation is there and the guidelines are established and the justification in changing practice is there, what is the approach to implementation? And I will say fundamentally the radiographers and the technologists are the face of this. They're the ones that this has most affected because they are the face of what we do. They're front-facing with patients. They're in the trenches. And I will say, to some degree, from a professional standpoint, imaging professionals in the United States did not account for this important thing. And it's resulted in some of the adversarial relationships between the professional societies. Documentation for the NCRP came out in January of, I think it was 2021 here, the basic reasons for doing this, but also came out with an implementation guideline that can be found on the website here. The AAPM had FAQs that are part of the implementation strategy, and these are for both technologists and patients. And again, I provide the resource here, frequently answered questions, and it comes with a brochure, which I think is patient-centered and intended to be something that will help both patients and caregivers understand. So an important tool in the implementation. And then additional information, as I've listed here, from shielding modules done in an AAPM library here, and the link is provided. So the changes will impact a number of different guideline, regulatory, educational things, and that's all of these things need to be considered for in terms of training technologists, including radiologists. Much of what has been taught in the past has to change. This includes the certification and credentialing kinds of things that are on examination, so it does take time. But organizations such as ASRT have supported this change. ARRT is again moving in this direction here, but I just listed some of the important societies, professional bodies, et cetera, that will need to be taking part in this change. Now, how do we move towards success? Again, the implementation guidelines the NCRP put out, I think, are quite good. Talks about how to have conversations, how to set this up, how to change policy, who to involve, et cetera. And the role of radiologists in this is in design and implementation must be supportive of the technologists and the radiographers, and it has to be informed to serve as a resource for point-of-care discussions with patients and caregivers. But we also have to, as professionals, engage the practitioners, because oftentimes the questions will be addressed to that level of care, the point of care too. And again, this information from the radiologist can serve to function as guidelines and regulatory changes happen as well. Now, I will say, again, there is some adversity here too, and while the ASRT has embraced this idea of not routinely shielding, there's still some information out there that in modules that says shielding should be placed when the imaging is out of field. For example, if you're going to do an wrist x-ray, you should continue to place shields. This is not consistent with some of the current recommendations, and this goes back to the issue that the cooperation between professional societies was not as good as it should have been, and we need to continue to have conversations, because while that doesn't provide any harm, right? Putting the shield on doesn't provide any harm. It just sets an inconsistent principle about shielding, because when you do an abdomen radiography, you provide a gonadal shield, and then you provide a gonadal shield when you do the wrists. The parents are saying, why are you doing this? So there are some additional cooperative efforts that we need to have here. So some of the changes you've heard about from Claudio here, it's going to take time. Why didn't we do this before as a professional society? What did we discover? We didn't discover anything. We just recognized some of the science here. Why do I, as a parent, have to wear a shield in the room, and yet you're not shielding my child? It's a great question, and we have to be prepared to answer that from an occupational exposure requirement standpoint. My dentist still shields my child. And we need to work with our dental colleagues to have consistent practices here. Again, it's an element of certification. It's easy to be judgmental and blame rather than take this as a combined effort of advocacy towards better care of children. And radiologists have been relatively disconnected from this patient-centered part of it too. It's easy to say, here's the policy, but if you don't address the issues with how the question's going to be taken for radiographers, technologists, how are they going to come to them, how to answer them, then it's not good. And when exactly is diagnostic potential compromised? Difficulties in the clinical environments. And I'll just put this up here. I have some comments, but after a session that I was involved with at the ECR in 2021, these are the kind of comments that came about. I mean, it was, and there were no positive comments that this is a great thing to do, we understand why it's being done, we totally accept this, it makes sense. Every comment was adversarial here, and so we still need to, on a global standpoint, do better at rolling this out and implementing this thing here too. And we must remember that this is not a prohibition. Sometimes people mistake that. There are situations and settings where it may be used, even if it doesn't do any good, just to reassure from a psychological standpoint to the parent that you're listening to them. So it's not that you can't do it, it's just the routine use of shielding should no longer be done here. So the effort is to move from routine shielding. The practice then should revise policy guidelines to be current, include other medical specialties, have a defined scope, Consistency is important across the practice enterprise. Talking points for radiographers and technologists are not only helpful, they are essential. This will take time. And just to remind everyone, there are so many worse ways to do radiography. We can't forget the basics here. For example, we don't need to do a chabdom extremity film where we're imaging the hands. Sometimes you get grandma's hands in there too, the abdomen when you're looking at the chest. These basic fundamental things, appropriate technique, including appropriate collimation, go much further than this issue of patient shielding. So do not forget the basics here. So thank you for your time and attention this morning. And I'd like to welcome to the podium Napapong for the next talk, and he'll give us a ISRRT perspective. Thank you. Very